this webinar session. And without much ado, I would like to go ahead with the particular presentation. This particular talk has a lot of relevance to what each one of us is facing in our day-to-day practice. And I think I'd like to keep it an open discussion and encourage questions from a lot of the participants towards the end of the talk. I think it's a very common perspective now that many of our patients are asking us the same question. Many of them are asking them whether they can be potential people who have a coronavirus. Some of them are cardiac patients, some of them have a history of angina, some of them have a history of having an angioplasty. So there are two kinds of patients that we see in the general population. One set of patients are those who do not have any major problem, but need to come in for a regular annual follow-up. So these are generally asymptomatic patients in the general population who come to us for a yearly annual checkup. The second set of problem patients are those who have ongoing problems. These problems can be just shortness of breath, can be chest pain, can be swelling in their feet or any other symptoms like that. So many of these patients obviously are very scared of visiting a hospital. This care is in a way correct in the sense that the government has tried to instill a sense of responsibility in all of its citizens to maintain social distance, to sanitize themselves, to wear masks, and to take all precautions as such. So obviously many people are worried about that. I get the question very often. Sakra has been a center for testing for COVID-19, one of the very few private institutions, the first few private institutions to start that. So people often call me and say, Dr. Adil, isn't Sakra a COVID camp? Isn't Sakra a COVID institution? Is it safe for us with chest pain to come to the hospital? Is there something that you can do online, on the telephone? Well, the honest answer to that is just like whether there's corona or no corona, every patient needs to be examined in certain cases, and certain medication can only be administered in a hospital and more so in an emergency setting. So it's important for us to encourage these patients to come into hospital and get their testing done. Once this is done, many of these patients require to undergo surgery or the like, and apologize for the fact that we've had a technical issue connecting my laptop onto the particular webinar with screen controls. But I would like to just go on and talk about a few of these aspects. The first aspect is that not every patient who has a heart disease requires a surgery. So it's important for us to understand that every patient who comes to us needs to be stratified. We need to understand the patient, we need to understand the risk, and we need to stratify the hospital that we are in. Now, the policy across the world, especially for cardiothoracic surgery in these settings, is to stratify the hospitals. There are three kinds of tiers: tier 1, tier 2, and tier 3. What is the difference between the two? Now, tier 1 is based on the total number of corona-positive patients who are admitted in the hospital. Now, Sakra, for example, is a mixed hospital. We have a separate designated zone, a separate part of the hospital that's exclusively for corona patients, and a separate part for non-COVID patients. So if we take the total number of patients admitted with COVID or the total number of COVID patients that a hospital is seeing, if this is between 0 and 30%, then the level of the hospital is a tier 1 hospital. Now, if the percentage of patients who we are seeing in COVID positive is between 30 to 60%, then the level of the hospital is a tier 2 hospital. Suppose we are seeing more than 60% patients who are COVID positive, it becomes a tier 3 hospital. Now, in a tier 3 hospital, the level of dysfunction of hospital or the dysfunction of the services is greatly reduced, which means to say the number of services that can be normally given to people is diminished by almost 70 to 80%. As opposed to a tier 1 hospital, in a tier 1 hospital as well, where the number of corona patients, if we are seeing anybody between 0 to 30% patients, then the amount of disability or reduced amount of hospital services that is there is very small. So it's called mild restriction of hospital activities. Now, in the case that a patient, even if a hospital has 0% corona cases. Does that mean we need to operate every single cardiac or thoracic or vascular case that comes to us? The answer is no. The reason being is there are specific guidelines. Now, we never know when the situation will change, so we need to stratify the risk of a patient. If a patient is absolutely asymptomatic and does not have any of the conditions that I'm going to share with you, then the patient can be electively asked to wait and get re-stratified. Now, what does re-stratify mean? Whichever patient that you have who's on your list for surgery gets a questionnaire via telephone every 2 weeks. So every 2 weeks, the condition of the patient is assessed and seen if he's in this asymptomatic group, which can wait, because the overall risk of waiting for surgery versus doing surgery is kind of balanced. So it's better to wait. In case in any of these questionnaires, the patient is noted to be of a high risk, then we need to switch the patient from this particular group onto the symptomatic group. Now, if we are a tier 1 hospital with less than 30% COVID positive patients, we need to operate all inpatients who have cardiac issues. That means if a patient is admitted to the hospital with ongoing chest pain, with an acute cardiac event, with an aortic dissection, or with acute heart failure. So in all ways, if a patient is an inpatient, that patient needs surgery. Now, in case a patient is not an inpatient, but the patient is symptomatic with a couple of conditions. Suppose a patient has severe aortic stenosis. The risk of waiting with aortic stenosis is very high. It's 8 to 10% per year, and it's cumulative. It keeps increasing. So these patients cannot wait, whether there is COVID or not. So a severe aortic stenosis patient needs to come in for surgery. Second, a patient who has blocks in the arteries, but these are not just regular blocks. If a patient has block in the entry of the left main coronary artery, called left main coronary artery disease. So if this patient is having symptoms or even mild symptoms or no symptoms, a severe left main stenosis patient needs to be advised to go for surgery. Suppose a patient has 3 blocks, but it's not in the left main territory, but the surgeon or the cardiologist feels that a large amount of the heart muscle is at risk, then these patients again are advised to go in for surgery. Suppose the patient has a large aneurysm, say an aortic aneurysm more than 6 centimeters, that we know has a high risk for rupture or a high risk for dissection, these patients need to go in for surgery. Suppose the patient has any other valvular heart disease apart from aortic stenosis and has symptoms of heart failure or symptoms like paroxysmal nocturnal dyspnea. These patients will rapidly go down and have a high risk without surgery. So we advise all these patients also to go in for surgery. Similarly, for patients who have HOCM, hypertrophic obstructive cardiomyopathy, these patients also have a lot of issues. If unoperated and if they have such kind of problems and they're symptomatic, they need to go in for surgery. All other patients, suppose a patient has a small ASD, a PFO, something that's stable, we need to wait. Now, if we extend and extrapolate the whole talk to include pediatric populations, any of the small children who have, something called cyanotic heart disease with low oxygen saturation or severe pulmonary arterial hypertension, these again are patients who cannot wait. For example, severe PAH with a VSD, or somebody who's got a TAPVC, a total enormous pulmonary venous connection. These are again children who need to go in for surgery, because without surgery, the risk of waiting is much, much higher. Okay? Now, this is when we talk about tier 1 patients. We have a second set of patients called tier 2 patients. Now, tier 2 hospitals and tier 2 patients is when the amount of coronavirus patients are between 30 to 60%. And in this case, the emergency services that we provide, most regular cardiac surgery should be stopped. And in this case, only certain amount of cases like inpatients who are admitted with severe heart failure or an acute dissection or ongoing angina, which is not controlled by medication, is not controlled by an angioplasty, these kind of patients need to go in for surgery. In stage 3, that is a tier 3 hospital, when more than 60% of patients admitted in the hospital are corona positive patients, Under these circumstances, we cannot do any kind of surgery except those surgeries without which the risk life to a patient is fatal, which means something like an acute ongoing failure or an acute ongoing dissection, some kind of a complication of an aneurysm. If something like this happens, then we can have the option of going in for surgery. So I always say in today's realm and today's world, whenever we look at cardiovascular surgery, there is an entirely new paradigm shift. We've seen different kind of symbols in the world. We've seen symbols for medical disease. We've seen symbols for recycling, restrooms, handicap, no smoking, no parking. But there's an entirely new symbol that's come in today's world, and that is the no COVID, the no corona symbol. Thanks to this particular virus, everything has changed in the world. The way that we do things, the way we greet our own loved ones, the way we work, the way we visit, the way we shop, everything has changed. And we've seen that the daily change for this has been global. As of probably 28th May as well, they're close to 130,000 cases being added worldwide. More than 6 million cases across the world. India is no different. As of yesterday, we had 8,000 cases, and I think today is going to be a special day. We're going to hit close to 9,000 cases, unfortunately. So there's a large burden in our country, and we all know that the COVID virus is not going to go away tomorrow. Even if you wish for it to go, it's not going to go away. And therefore, the whole idea behind this webinar is because not just healthcare systems, but physicians like us, we need to relearn everything for our patients. The whole idea with us trying to relearn and understand two critical issues, especially with cardiothoracic surgery, is do we do surgeries now or whenever corona goes away? And if a patient comes in to the hospital for a surgery, what is the risk of exposing such a patient for a hospitalization? Because these are very commonly asked questions to me, and I'm sure many of your patients will be asking you the same question. So the basic principle, whenever a patient needs to be treated in some conditions, is threefold. We need to protect the patient, we need to protect the healthcare team, and in between, protect the institution and society, which means we need to stratify and see what we're doing is right, is justified or not. And this is the slide which I was telling you about the tier 1, tier 2, tier 3. Very carefully when you look, if the number of patients with COVID is very low, they fall into tier 1, if not tier 2, and then tier 3. Fortunately, I'm happy to say that even though we've been a center for testing and we have done close to 1,000 samples and tested in Sakra alone, we've not had a single positive patient. So I'm proud to say we're still in tier 1 and we're at the 0 mark. And because of which, this is a slide that I already explained, only certain patients, all inpatients or patients who are symptomatic, things like coronary artery disease or an aneurysm or HOCM or heart failure or symptomatic mitral stenosis, irrespective of the corona situation, they should go into surgery, because without surgery, their risk of dying or having an adverse event is much higher, and the risk with getting a corona infection, although it's present, it's very small. So outcomes of patients are still better in such conditions. Suppose you fall into tier 2, we have lesser number of patients who we can operate, specifically those who are inpatients. And if you have, more than 80%, 60 to 80% patients with COVID positive results, we have to be very careful. And only those who cannot be discharged without the surgery, extreme life-saving operations, those are the only ones that need to be done. So I've formulated a slide, I call it the 10 commandments in cardiothoracic surgery in times of COVID, going after Moses and the 10 commandments that he gave to the people. The 10 commandments are, we need to do surgical triage. Means we need to assess which place goes where. You have less space in your fridge and you need to shift your items in your fridge from one end to the other to make unit. That is what triage is about, because whatever said and done, we're a large country, we have too many people, we have less number of beds, and although every now and then we get the update on WhatsApp that we have enough PPE, quality PPE is still in shortage, resources are limited. So we need to triage them, we need to see what kind of a tier our hospital is. whether our hospital is a tier 1 hospital, tier 2 hospital, or tier 3. Depending if our hospital like Sakra is a tier 1 hospital, then we know that all asymptomatic patients, with the exception of those I've explained, they can wait because the timing of surgery is still flexible. Whether you wait or do surgery and then do the surgery later, the risk is the same as opposed to corona. But anything that's done, an emergent or an urgent procedure, like I told you with the aortic dissection, endocarditis, patients who have severe aortic stenosis or severe symptomatic mitral insufficiency or stenosis need to go in for surgery, because without surgery, the risk of dying or having a bad outcome is much higher than the risk of having COVID-19. And I always discuss this. Number 4 on the 10th commandment, but very, very important, is you need to have a one-to-one discussion with every patient prior to surgery, saying that although you may not have COVID-19 prior to surgery, there is a possibility that you may get it later on, maybe in hospital, maybe once you go, maybe 2 months down the line. And when you do so, you need to know in the first 30 days, if you tend to become positive, there is a higher chance of you having problems. We all have read time and over again, people above the age of 60, diabetes, untreated, uncontrolled, cardiac failure, cardiomyopathy, low ejection fraction, all these people are at high risk. But just imagine if these patients get COVID positive, their outcomes are going to be lower than if they've been treated for the same. Data right now from China, has shown that if a patient has been treated out there, then the overall risk after they get the infection is actually slightly lower. So we need to understand that. Now, in the event that a patient prior to surgery is COVID positive, then what do? Now, we need to understand there's a landmark paper, just 2 centers across the world have published data that, for example, if you're doing a bypass surgery, the risk of bypass surgery is 1%. But if you're COVID positive and you do bypass surgery, then the risk of surgery becomes 20%. So I encourage people that when they come into the hospital and they're scheduling surgery for me and they have symptoms, I tell them it's imperative that you undergo a COVID-19 test. It's not for me, it's not for the hospital, it's for you. Because if you are COVID positive, we would rather wait till you're COVID negative and then do the surgery, simply because a 1% risk becomes 20% risk if you're COVID positive. A simple analogy I tell people, it's like jumping from the first floor without a parachute and jumping from the 20th floor. Yes. So that's commandment number 5. And commandment number 6, we tell everybody, is we treat every patient as a potentially positive patient. Why? Because while you're doing this, you decrease the risk to healthcare personnel as well as to other patients in the hospital. So we take something called universal precautions. Now, we've seen that there was a time that we never used to do HIV, HCV, or SVH, SVSAG to everybody. But today, with universal precautions, we really don't need to worry about that. And we can do that as universal precautions to prevent everybody involved from getting the infection. Now, the next commandment is that we need to optimize our resources. No other surgery requires as many blood transfusion as does cardiac surgery. And in these situations, blood donors, especially voluntary blood donors, are very rare and will keep getting rarer. So what do? We need to choose a surgery that requires less blood transfusion, less chance of infection, less hospital stay, and all of them adds up to just one kind of surgery, and that's minimal access surgery. If you can do a bypass surgery by a regular technique and you can do by minimal access surgery, why not? A, because you're going to stay in hospital, your patient is going to stay in hospital for a lesser time. Your patient is going to have less need for a blood transfusion and a less chance for infection, and this has been proven time and again. So this is also a recommendation by the American heart surgeons as well as the Canadian and the European heart surgeons that whenever possible, if you're operating in COVID times, try to give the patient a minimal access surgery so the recovery is faster and the use of all these other resources is minimized. The stay in the hospital in the ICU is minimized. This next commandment talks about using a certain tool called the STS resource utilization tool. Now, this is updated every day from data across surgeons across the world and North America, including myself, that tells that if you have X, Mr. Ramu, who has this problem, how many days do you anticipate for him to stay in hospital? What do you anticipate the complication rate to be? How much blood do you anticipate him to have? So this particular tool is a calculator. And this calculator is based on actual patients being operated under the present conditions, and it helps you estimate how long your patient is going to stay in hospital if you operate him today, how much blood you're going to use, how many days he's going to put into the ICU, and so on and so forth. All right. Now, specific indications for ECMO. ECMO is something that takes care of your lungs if your lungs are not working. It was the go-to step that everybody, especially in the United States and the UK, as well as in China, were doing, because we know in COVID-19 your lungs don't work. And your lungs don't work, use an artificial heart-lung machine like the ECMO, extracorporeal membrane oxygenation circuit. But we need to know that although it sounds beautiful on paper, it's a double-edged sword. Most of the patients, by the time they come into ECMO, are very advanced in the stage of the disease, and ECMO, paradoxically, for COVID-19 patients, does not have great results. So much so that the risk for such patients can approach almost 60 to 70% mortality. So although we have ECMO at Sakra and we do offer it to patients, we're very, very judicious in using the ECMO for the critically ill patients, if at all the situation arises. Also taking care into caregiver as well as patient attender confidence that the results may not be all that great as we hope it to be. And last but not the least, it's very important, just like we do at home, just like the shopkeeper on the street does, just like the little child crossing the road does, we need to protect ourselves, we need to protect the patient, and we need to protect the team. Whether we're operating as a cardiac surgeon or developing like a general surgeon, we need to take care of all the same. So another thing that we do, what do we do to mitigate exposure risk? Now, this was a very, very important thing that the infection control team at Sakra had kind of brainstormed before we actually resumed services. I was happy to say that we had services going on with all of this intact right from April, and we continue to do so in providing cardiac surgery, essential life-saving cardiac surgery for the people who required it. How did we achieve this? We did this because we have a separate set of thinkers and engineers who mitigated the exposure risk by creating a separate COVID zone, a totally separate zone, an outhouse. You know, all the patients who were either COVID positive, we didn't have COVID suspect to be positive, were in a separate zone called the COVID zone. We called it the R zone or the respiratory zone. What we did was very quickly use Japanese Toyota lean management technologies to duplicate the set of services we had. We had 2 sets of X-ray machines, we had 2 sets of labs, we had 2 sets of healthcare personnel. Now, these kind of people never intermingled. It was a separate unit. It was like Alcatraz prison, separated out. Even I couldn't go there unless, and if I needed to give any kind of consultation with that, I needed to do it through a teleconferencing app. So there was a separate OT, a separate ICU, ward, and even outpatient for patients who were even suspected to be COVID. Why was this important? Because this was important not only to protect those patients, but also regular patients who we knew didn't have corona positive in them or were not even COVID suspect. By mitigating this risk exposure and totally creating maybe like something like an entirely new zone, a new hospital, we were able to separate these kind of patients, potential patients, from the regular set of patients. This, along with exposure risk in non-COVID zone, what we do is effective screening, thermal scans, all the other things. Even basically, we've been able to take a lot of our patients in for inpatient screening for COVID. Now, as of today, the ICMR guidelines gives a separate 5E, that is something called an others category, which means inpatients in hospitals can be effectively screened for COVID. And once we do this, we still follow universal precautions for certain high-risk procedures, even if a patient is negative. And these include aerosol generating procedures. A very common aerosol generating procedure is something like an intubation for anesthesia. No matter whether the patient is positive or not, everywhere you still need to use some form of PPE, use a regular sanitization and masks. Whether it's your home or whether it's the hospital, the hallmark for basic guidelines stays the same. By doing this, not only do we protect ourselves, our patients, but also future patients going on. I'm proud to say that thanks to all of this, Sakra as of now is in tier 1 with a 0% risk, inpatient COVID load. And hopefully by these things and the cooperation of all our supporting doctors, as well as the supporting facilities, as well as the patients who come into the hospital, we'll be able to try and maintain this particular standard. Last but not least, we need as a recap to know that our disease is going to progress. COVID or no COVID, it doesn't matter. We need to stratify the risk of the patient and know those are the patients who still need the surgery, without which the risk of them dying or having an adverse event like a stroke or a major morbidity is very high. We need to know where our hospital stands, which zone we stand. Follow those principles, follow the principles of risk mitigation, because even in the times of Corona, we have shown and proven over the past 2 months that we can have safe and very good outcomes by adapting to these risk mitigation strategies, by using technologies like minimal access, least invasive surgery to provide the benefits to our patients. So thank you one and all for your time and patience. I apologize for the slight delay and the technical issues that we have. I wish I could blame it on the coronavirus, but I can't. This is one thing that's not related to COVID-19, and I'd like to open questions for the panelists as well. So without mask, can we prevent corona? Well, I mean, there've been a lot of WhatsApp forwards about using cow urine and dung and things like that, but I don't think that's possible. You know, I hate to say this, if you don't use a regular mask, it's very simple. Corona spreads by, you know, droplet and spread that way. So using a mask prevents this particular sensitive area. Using a face shield prevents this area, and I think it's one of the very few essentials. If you do not use, but I can tell you something, if you do not use a mask properly, if you do not use a face shield properly, then you can still get corona. So I think the reverse is actually true, and yes. Okay, we've got a couple other questions. Yes, how far is the duplicate personnel is set up, is feasible in the India? So there was a very good question. How do we duplicate the personnel and staff, and how is it feasible in the Indian setup? I have a very simple question to most of our healthcare providers. How much do you think your hospital or your private practice has come down during Corona times? 10? 20, 30, 50, 70, 80. I know for a fact that a lot of the times in the hospitals, the total number of patients, the total number of patients have come down in some hospitals 60, 70%, 80%. If your hospital needs to be a dedicated COVID hospital, you don't need to do the duplication of staff. But if you want to be a mixed hospital treating COVID patients, it's very important to duplicate your personal staff and do it. Your total capacity for the non-COVID zone may come down, but it will still safely protect your patients and your healthcare personnel. All the PPE that you're trying to do goes into the COVID zone more than the non-COVID zone. So on the front, it looks like, oh, it's very difficult. How can you do it? So what we started doing in Sakra is we started allocating around 20 to 30% of our personnel into a COVID zone. So we started maintaining that. So 60 to 70% of the hospital was still doing all the regular work. Now, the reason we've been able to manage for the past 2 months is because overall our work has come down by maybe 40, 50%. So since we're going at 50%, the 70, that 30% reduction was still enough. Yes, it will be possible in the Indian setup if we are expecting full 100% capacity or 90% occupancy in the non-COVID zone. That is going to be difficult and that is going to be expensive. Next question. Yeah, do you take the risk of operating COVID cases if you feel cardiac surgery is a must for that patient at the moment? Absolutely. I think when we took the Hippocrates Oath, this question was answered already. If I do feel that cardiac surgery is a must for the patient, we're one of the first few centers in Karnataka who has donned complete PPE, full PPE, right from intubation to surgery to post-op negative isolation rooms to see that. Of course, we did have an added point. We also simultaneously tested our patients for COVID-19 and used that test to see what was going on. So yes, I think if the risk of a patient getting COVID-19 during hospitalization is say 10, 15, 20%, and the risk of him surviving without surgery is very low, then it's better to do cardiac surgery. So I think it's important for the patient, yes. But if a patient is asymptomatic, then we will wait, absolutely. During pregnancy, what kind of special care to take patient during Corona? Thank you so much for that particular question. Although it's not directly related to cardiac surgery, I can do answer that question. Data right now say that during pregnancy, almost around 45% of people who were sampled in different hospitals in New York, New Jersey, and the UK, asymptomatic patients pregnant were found to be positive. So during pregnancy, I think what we discussed out here, everything has some form of PPE, especially in the labor room. Splashes and spills are very common. So PPE is a must. Deliveries go on. And I'm proud to say that the gynecologist team at Sakra, led by Dr. Prabha, have been actively going on with their deliveries, taking full PPE and managing show. So how far safe is MICS in emergent condition with with left main unstable patient as against opener? Yes. Now the simple rule is this: if the condition is an emergency condition, suppose there is no corona, if the patient is unstable hemodynamically and requires a surgery, I will not do MICS. It's my golden rule. So whether there is corona or not, I would not do MICS. In the setting of corona, having an emergency with an unstable patient hemodynamically, I would not. But if a patient who needs an emergency surgery but is hemodynamically stable, we can safely do MICS and we have done that as well. Okay, I have one more question here. Yes, if a child is having any anomalies, I'm sorry, I didn't follow that whole question. Yes, if a child is having any anomalies, how do we manage them? I'm sure there are lots of anomalies, but I'll just stick to cardiac anomalies. A lot of the common anomalies, the most common anomaly that a child is born cardiac is a VSD. VSD, left to right shunt, no severe PH, please wait. Like I said, this falls into the asymptomatic structural heart disease that can wait. If a patient has an ASD, a VSD, a PFO, a small PDA, please don't do anything. The only time, if a child has a tetralogy or a cyanotic heart disease and the saturation is above 80%, please wait, don't do anything. If a child has an anomaly that is causing some kind of hemodynamic compromise, if the saturations are going in the 60s or 70s, then we need to do an emergency surgery. If a patient has an anomaly like a total anomalous pulmonary venous connection, all TAPVs are potential life-threatening, and we need to take such patients. So these are the kind of things that we do with child having anomalies to cardiac surgery. Let's answer. Thank you so much for wonderful questions. I wasn't sure if everybody was listening, but going by the number of questions, I am happy that my marketing guys have done a great job out here. Okay, so are there drug interactions treating cardiac cases along with COVID treatment in COVID positive patients? Yes, they are. Unfortunately, they are. If anybody across the world can put their hands up and tell them, you know what, we have found the exact treatment for COVID positive patients, well, you know, I'm sure Trump would step down, but that is not happening. And we don't have a definitive answer. Today, one day we have remdesivir and the next day it's under trials. One day we have HCQs, the next day it goes on. So what happens right now is a lot of drugs which are being tried for COVID positive patients have, you know, not great safety margin. So if a patient is COVID positive and undergoes cardiac surgery, I've told this during the talk, that patient has more, for a simple CABG, which regularly requires only 1% risk, they have close to 20% risk of mortality. Now, if you add into that the treatment that we have for all the existing trials of drugs for COVID, there are going to be drug interactions for sure. The data on this is not clear, but from whatever we have only 2 hospitals from Hunan who have done that and have given us the data. The data shows the adverse reactions to drug varies from 11% to, believe it or not, a staggering 55%. So it could be just a minor reaction, but they've classified as a drug reaction. So that's something that we need to be careful. So my epitaph is, if a patient is cardiac positive, is COVID positive, we need to see can we kind of get them to be COVID negative before we do anything and then move on? How does it go on? So that's the thing. So let us see if there are any more questions. Just hang on. Oh, we have one more question that's come in. Okay, great. So we have a survey which will pop up on your screen right after the end of the webinar, and it takes only a few minutes to complete it. Please do complete the survey. For all those people who successfully complete the survey, the marketing team at Sakra is going to send a 10,000 rupee gift hamper. I'm just joking about that. I'm just joking about that. But please, I just want to catch your attention. Please take the time out to complete the survey. We want you to do that. We want you to know what you liked and what you disliked. I know we had technical issues, but please give us your feedback. We truly want to know. We've been able to make this happen only because of your interest and active participation. Thank you, one and all. Stay home, stay safe, go to hospital, take care of patients.